Today's lecture is about general radiography. Let's look at the objectives for today. After today's lecture, students will know about X-ray system components. Students will be able to discuss X-ray projection imaging and direct and indirect X-ray image acquisition systems. Students will be able to identify the image characteristics of direct and indirect image receptors. We shall learn about technique factors and imaging applications. Students will learn to estimate dose and how various technique factors affect patient dose. We shall end with quality control. In radiography, as in most imaging, the X-ray tube and the image receptor are the main components. The X-ray tube produces X-rays when energized. The X-rays pass through the patient and are collected by the imaging receptor. The quantity of X-rays passing through the patient may be set manually or controlled by an automatic exposure control system. The area of the patient that is imaged is set by a collimator, and image contrast is enhanced by reducing noise with an anti-scatter grid. The use of a grid increases patient dose by the Bakke factor. Let's briefly review these system components. The main components of the X-ray tube are the cathode and anode. The kV we select in radiography is the potential difference between the cathode and anode, and the MA is the tube current. Both kV and MA selections depend on the power rating of the X-ray generator. Power is defined as current times voltage. A 20 kilowatt generator will have a combination of allowable kVs and MA values that will combine to give 20 kilowatts. For example, if the available kV on a 20 kilowatt tube ranges from 40 kV to 140 kV, then the MA range will be from 500 MA at 40 kV to 143 MA at 140 kV. In practice, you may not get these exact numbers for a 20 kilowatt tube because although the tube may be rated as 20 kilowatts, it may actually be 19.8 kilowatts or some other number. Here is a question you may try. For a 100 kilowatt CT generator, if 140 kV is selected, what is the maximum allowable MA? A collimator restricts the X-ray field to the anatomy of interest and is important because it protects other parts of the patient from receiving unnecessary radiation exposure. Also, by restricting the field size only to the anatomy of interest, scatter is reduced, which reduces patient dose and improves image contrast. This slide shows several collimator arrangements. The aperture diaphragm shown on the top is the simplest of all beam restricting devices. It is basically a lead or lead-lined metal diaphragm that is attached to the X-ray tube head. Radiographic extension cones and cylinders are considered modifications of the aperture diaphragm. The light localizing variable aperture collimator is the most used beam restricting device in radiography. A picture of this collimator is also shown on the bottom left. Once X-rays exit the tube housing, the beam can be shaped by using different shaped filters. These shaped filters allow for imaging different non-uniform body parts by attenuating the beam intensity to allow for more intense beams for thicker anatomies and less intense beams for thinner anatomies. These filters are called compensating filters. Several compensating filters are shown on this slide. Wedge-shaped filters can be used when imaging wedge-shaped anatomies like the foot. A trawl may be used to image the chest to allow for more intense X-rays through the mediastinum and less X-rays through the lungs. Bow-tie filters are commonly used in CT imaging, and cones are used in digital fluoroscopy imaging. In the lecture on X-ray projection imaging, we looked at image acquisition systems from the image receptor perspective and classified them as either direct or indirect systems. I will review the main classifications we arrived at. Screen film systems were classified as indirect detection analog imaging systems because a screen is used to absorb X-rays and convert it into light. The light exposes photographic emulsion to generate the image. A photostimulable phosphor was a direct detection analog imaging system because X-rays are absorbed directly by the storage phosphor to produce a latent stored image. The latent image is read out in a raster pattern by optically stimulating the storage phosphor. We classified flat panel systems based on cesium iodide scintillators as an indirect detection system because a cesium iodide scintillator was used to convert X-rays to visible light. We also classified a system that uses amorphous selenium to directly convert X-rays to charge as a direct digital detection system. The main advantage of a direct digital imaging system compared to screen film analog systems is dynamic range. Digital detectors can operate at any speed because of a wide dynamic range. This slide shows a few images acquired with a screen film system at low exposure, proper exposure, and high exposure. The screen film system will show a poor image for overexposure and underexposure because of a fixed film speed as shown by the HD curve. A digital detector can always correct the image to show proper exposure whether the image is under or overexposed because the speed can be shifted by just moving the curve as is shown on these images. Let's now look at some acquisition systems from the X-ray tube perspective. We shall start with dual energy acquisitions. Some X-ray systems come with two X-ray tubes and are called dual energy systems because X-rays can be acquired at two different energies for dual energy radiography. Different manufacturers implement different dual energy schemes, but those are outside of our current scope. Dual energy radiography is a form of subtraction imaging. We know from the photoelectric effect and Compton effects that different tissues have different energy dependencies. Because of these energy dependencies in tissue types, when we acquire two radiographic images at two different kVs, we can remove either the bone component or the soft tissue component in the image by post-processing. The top figure shows a chest radiograph at two energies. The bottom image shows the bone subtracted image leaving soft tissue and the soft tissue subtracted image leaving bone. A common problem in radiographic imaging is structures superimposed on each other. This can hinder the detection of lesions and can also produce false positive results. Linear tomography makes use of a standard radiographic X-ray set where the X-ray tube and cassette holder are connected so that during exposure, the X-ray tube and cassette move in opposite directions about a pivot point. The pivot point is adjusted to the height of the desired image plane. The resulting image shows sharp detail in the imaging plane and progressive blurring of detail outside this plane. The top image shows a tomographic attachment to a radiographic system. The two images to the right are of an abdominal radiograph and a conventional tomography image with desired focus plane shown. There are some features of note in tomographic imaging. The farther an object is from the focus plane, the more blurred its image will be. The larger the tomographic angle, the thinner the tomographic section. The use of conventional linear tomography has declined over the years, largely due to the increased use of digital tomosynthesis and computer tomography. A digital tomosynthesis system has a motorized crane that allows the X-ray tube to be tilted at an angle as it is swept along a linear path so that the X-ray beam is always directed at the X-ray receptor. This is shown in the left image. Compared to conventional linear tomography where a single plane is in focus, in digital tomosynthesis, each image is available in digital format and can be reconstructed using filtered back projection to create a 3D matrix of values, each representing a voxel. With these digital images, any tomographic section can be reconstructed with enhanced contrast. The rightmost image shows a digital breast tomosynthesis image to the right compared to a single view breast image to the left. You can see the difference in image quality. On this slide, we have a digital tomosynthesis image of a chest compared to a standard single view chest image. The digital tomosynthesis image shows superior in-plane resolution. Chest digital tomosynthesis uses all the same elements of a regular chest radiographic system, except that a digital tomosynthesis system has a motorized crane that allows the X-ray tube to be tilted at an angle as it is swept along a linear path so that the X-ray beam is always directed at the image receptor. The same approach of using filtered back projection to reconstruct a 3D matrix of voxels is used. Any number of images can be reconstructed at multiple depths from a single set of projection images. Each image can have enhanced contrast for the best quality. Let's look at a few image characteristics listed here based on the types of imaging systems used. We can start with spatial resolution. This slide demonstrates the influence of image detector on spatial resolution of an image. You can see the difference between a cesium iodide-based detector and a selenium-based detector. How would you classify these two detector types? The spatial resolution in these images is from the detector point of view. From the X-ray tube point of view, spatial resolution is also influenced by tube focal spot size. Most radiographic tubes are dual focus, meaning there is a large focus and a small focus. The small focus is used for imaging structures requiring high spatial resolution but little tube current. An example is when looking for fractures of the hands and feet, the small focus will be selected. On this image, scatter removal with grid is shown to improve contrast. The Backy factor is 8 on this image. Higher grid ratios will remove more scatter but at the expense of more dose because of higher Backy factors. The left image is acquired without grid and the right image is acquired with grid in place. More scatter removal is achieved with grid than without grid. All X-ray imaging modalities contain some noise. This noise is dominated by quantum motile, which relates to the total number of X-rays used to generate an image. Noise gives the image a mottled, grainy, textured, or snowy appearance. From an X-ray tube point of view, noise can be reduced by increasing the number of photons as shown in the image below. Noise can also be reduced by using image receptors with higher absorption efficiencies. An important formula to keep in mind is the relative noise formula above. It is stated here in a more useful form as relative noise is inversely related to the square root of signal. So, for example, if you have an image that has some level of noise, if you double the signal, the noise in the image will be reduced by square root of 2 or 1.414. If you increase the signal by a factor of 4, the noise is reduced by the square root of 4 or noise is cut in half. You can go the other way with this exercise. For a certain initial level of noise, if you were to cut the signal in half, the noise will increase by a factor of root 2. If you cut the signal by a factor of 4, the noise will increase by the square root of 4 or noise doubles and so on. Temporal resolution is also important in radiography. In radiographic imaging where moving structures are part of the image, a short exposure time is always desired so as to freeze the motion. This may also require a higher tube current. In certain video studies involving moving structures, assuming you have a suitable frame rate of say 30 frames per second, the appearance of continuous motion in the video depends on the pulse rate. For example, in swallow studies, a higher pulse rate gives better temporal resolution than a lower pulse rate. Note that higher pulse rates also involve higher patient doses. Examples of pulse rate settings are 7.5 pulses per second, 15 pulses per second, 30 pulses per second. Cardiac studies may use 15 pulses per second or 30 pulses per second. Let's consider some general radiography application requirements. Each of these applications has specific requirements for source to image distance SID, KV, and MAS. To learn about these applications, I have shown here a manual technique chart. A technique chart is a table that contains various technical data to help radiographers obtain a consistent, standardized image at the lowest possible radiation dose. This chart shows the body part imaged, the KV, the SID, MAS, and whether a grade is used or not. This chart also shows adjusted techniques for small, medium, and large-sized patients. This is not meant to be an all-inclusive chart. Let's look at, say, an adult AP chest technique with grade. For a medium or average patient, a possible technique is 100 kV, 3 MAS at 72 inches SID with grade. When looking at the chart, take note of the MAS levels. Highest MAS is done for thicker body parts like abdomens and C-spines, and the lowest MAS is for smaller body parts like extremities. Another application requirement is whether the image is acquired with table Backy or with wall Backy. Because table Backy images are acquired at 40 inches SID, use of the correct grade is important. Wall Backy images of the chest are usually acquired at an SID of 72 inches. The use of a wall grade in a table Backy or vice versa can lead to image artifacts and unnecessary dose to patients. The chart shows the SIDs used for various body parts. Dosimetry is important for X-ray imaging because of the possibility of deterministic and stochastic effects. In radiographic imaging, the entrance skin exposure or entrance surface dose ESD is used for calculating organ doses. It is the dose to the skin at the point where the X-rays enter the body. Once the ESD is known, the appropriate radiation weighting factors and organ weighting factors are used to calculate the effective dose to organs beneath the surface of the skin. We shall see in the next few slides how to obtain effective doses and how to optimize techniques for image quality and dose. Here is a table of the entrance surface doses that a patient could receive for some standard radiographic techniques. Note the highest and lowest doses. Lateral lumbar spine and lateral T-spine are the highest doses, and non-grade PA chest is the lowest. Entrance skin exposure depends on various factors including KV, MAS, and patient size. With larger sized patients, higher techniques are used, leading to higher entrance doses. There is also more scatter contributing to higher organ doses. I mentioned earlier that once you have the entrance surface dose, you can calculate effective dose. Effective dose is used to compare the effect of irradiating certain organs to irradiating the whole body. It accounts for cancer mortality as well as hereditary effects. Effective dose is equal to equivalent dose multiplied by the tissue weighting factor for an organ. Equivalent dose in millisieverts is the dose in milligray multiplied by a radiation weighting factor. If there are multiple types of radiations, the dose in milligray is multiplied by a factor for each type of radiation. In radiography, where we only have X-rays at diagnostic energies, the radiation weighting factor is 1, so the equivalent dose in millisievert is just the dose in milligray. So as an example, if a patient came in and received an AP radiograph of the skull, you could use the entrance surface dose for an AP skull exam as the worst case scenario and then estimate the fraction of dose in milligray each of these organs on this table will receive from the dose to the skull. You then multiply the fraction of dose in milligray for each organ by the radiation weighting factor for that organ and add them all up to get the effective dose in millisieverts. Some organs should receive little or no dose if they are far enough away from the skull, so they will make little or no contribution to the effective dose. The traditional unit of effective dose is the rem, but the SI unit is the sievert. From our previous discussion about calculating effective doses, we should learn about how to calculate dose to an organ at some depth d below the skin. The dose to an organ at depth d can be calculated using this formula shown here. The formula uses the entrance surface dose ESD, the source to skin distance SSD, and effective linear attenuation coefficients to calculate dose to an organ at some depth d. Other correction factors can also be introduced for organ doses that are outside the actual field of view. Organs outside the field of view will likely receive some scatter radiation. While the previous formula allows for a more detailed estimate of organ doses, we can easily estimate organ doses at some depth in tissue by using our knowledge of the ESD and the half-value layer of soft tissue. We can use powers of half to estimate dose at different depths as shown in this formula if we know the half-value layer of tissue. To find the dose to organs beneath the skin, we can use a tissue half-value layer of about 4 centimeters. For example, if the ESD is 8 milligray at the surface, at a depth of 4 centimeters, which is one half-value layer, N will be 1, so the dose will be 4 milligray. At 8 centimeters or 2 half-value layers, N is 2, so the dose will be 1/4 of the surface dose, and so on. This method can be applied to fetal dose estimates. The last bullet is a practice question to estimate dose at depth for different numbers of half-value layers. Before we get into technique optimization on the next slide, let's look at some parameters associated with digital imaging detectors. When screen film detectors were commonly used, you could extrapolate the optical density of film to patient dose, at least in the linear portion. You knew that a high optical density film meant a higher patient dose, and a low or light optical density film meant a low exposure and a low patient dose. With digital detectors, that rule does not apply anymore. Recall this image from a previous lecture showing the HD curve for screen film and the line for a digital detector. The important point to remember is that a digital detector has a wide dynamic range and better sensitivity at low doses than the screen film system. It is also more forgiving at higher or lower doses than a screen film system. This table shows some symbols used by digital detector manufacturers to characterize parameters representing the exposure reaching the detector. This is important because although digital detectors are very forgiving, they must also be imaged at some predefined exposure ranges for proper diagnostic quality for each anatomy imaged, and also for proper dose savings for the patient. An important point to remember is that these numbers in the table do not necessarily relate to patient dose. Now that we have learned about different X-ray image acquisition techniques and ways to improve image quality, we can learn about how to optimize these techniques. Technique optimization involves several steps and embodies the LARA principle. The goal of optimization is not just to reduce dose but also to ensure that the image quality is adequate for diagnosis. There are a few basic principles that can be used as a starting point. Always use the shortest exposure time possible to freeze motion. Select the KV that gives the best penetration and enough MA to give a good signal to noise ratio. Adjust KV when contrast is used. For example, with iodinated contrast, a KV of 100 can be used to enhance differential absorption. Use grades when appropriate. There is no need to use grades for thinner anatomies like hands and feet. Note that for most X-ray tubes, the KV and MA are connected by the maximum power available for the tube. So for a 10 kilowatt tube, if you select 120 kV, the MA available will be limited to about 83 MA. So it is important to keep in mind the trade-off between kV and tube current because of tube power limitations. The selection of appropriate image receptor technology is also important because different image receptors have different sensitivities and pixel sizes that can limit contrast and spatial resolution. And finally, appropriate beam filtration affects patient dose and image quality. Too much filtration means low patient dose, but it also means fewer photons reaching the image receptor, leading to poor image quality. Balancing all these factors is key to proper technique optimization. A medical physicist can assist with technique optimization for different modalities. This table summarizes the influence of various factors on patient dose. Plus means increases, minus means decreases, and zero means no effect. Take a look at what an increase in the factors in the first column will have on patient dose in the second column. For example, an increase in SID reduces patient dose. Examine the table for different effects. So far, we have discussed the physical principles of diagnostic X-ray imaging systems. For X-ray imaging systems to continue producing good images at reduced dose to patients over a long period of time, they must not only be well designed, but must also be well maintained. It is essential to have regular performance monitoring as part of a robust quality assurance program. In this section, I will mention a few of the tests that should be carried out on the various components of the imaging chain as part of a QC program. These tests are usually done as part of a regular maintenance program by a biomedical engineering group and as part of annual physics performance evaluations by a medical physicist. Tube and generator tests are done annually per policy or whenever there is a change or repair. Tube output and exposure time are also part of annual performance evaluations. Half value layer and tube KV are measured as part of beam quality tests. Light beam and X-ray field are measured to ensure that they are properly aligned so that the desired anatomy is imaged each time. This is a sample of some of the required tests for radiographic imaging. We will learn about other tests as we learn about other modalities. Let's finish up with a few questions. First question, match the image to the acquisition method used. Your images are coronal CT image, single view radiograph, digital tomosynthesis image. The correct choices are coronal CT image is C, single view radiograph is A, digital tomosynthesis image is B. Next question. A patient comes into radiology complaining of hand pain. What is the appropriate technique that can be used for imaging the hand to check for fractures? The choices are A, 68 kV, 3 MAS, grid, large focus. Choice B, 68 kV, 1.8 MAS, small focus. Choice C, 80 kV, 30 MAS, small focus. Choice D, 95 kV, 20 MAS, grade, large focus. The correct answer is choice B, 68 kV, 1.8 MAS, small focus. Next question. Which of these will not lead to an increase in patient dose? Your choices are: first choice, increase in patient thickness; second choice, increase in MAS; third choice, increase in total beam filtration; fourth choice, increase in grid ratio. The correct answer is choice 3, increase in total beam filtration. This is the last slide. Thank you for watching this presentation.